Am I
Yes,
visible?
you're audible. Yes, you're audible, ma'am.
Okay, okay. And is the screen visible? All going good? Right. Okay, I have a message from Anu. Yes, ma'am. Yeah. Okay, okay. That's a heads up, I think, from everybody. At the very starting, I want to have a raise of hands, a show of hands as to who all have participated in the last webinar, which was on GTG 37A, prevention of VTE in pregnancy. Okay, okay. So, based on our last session that we had discussed GTG 37A, prevention of VTE in pregnancy and puerperium. So because you all had requested to carry on with the counterpart of the previous guideline, that is GTG 37B, which is acute management of thromboembolic disease in pregnancy and puerperium. So here we are today discussing the same. Now, if you've been in the class before, you know we want an interactive group. We want all of you to be able to unmute yourself, to drop in your questions. There are SBAs, EMQs along the slides that I'll be sharing. I want you all to be very active, very responsive. If possible, unmute. If you don't want to, then you can drop in your answers in the chat box. But we want a session where everybody is attentive, everybody is focused, and everybody is participating, most importantly. Okay. So starting off today about acute management, like we have tried preventing, but okay, unfortunately, we had not been able to prevent an unfortunate incident, and a venous thromboembolic disease had actually occurred in a patient who is pregnant or is in puerperium. So moving on, the first thing I would like to the first thing I would like to focus on over here is the signs and symptoms. Now, you might be asking that, ma'am, signs and symptoms, we all know. We are all clinicians practicing in our day-to-day lives. We know what a DVT looks like. We know what a pulmonary embolism looks like. No need to discuss something so basic. But let me tell you something, that it is important to have the buzzwords, the keywords in mind. DVT, that is deep vein thrombosis. Of course, it originates in our legs, and leg pain, leg swelling, which would be usually unilateral. When you see anything, any word related to a pregnancy and the patient having leg pain, leg swelling, we immediately think of DVT. No confusion there. Okay. So what about this third point? Lower abdominal pain, that is extension of thrombus into pelvic vessels. Now, over here, I want you to know that deep vein thrombosis, that vein can actually be any vein in the body, but most commonly, we see the veins of the left leg and the left common iliac veins, or the left pelvic veins, that are getting affected. So leg pain, leg swelling, we instantly identify that the question is pointing towards DVT. What about lower abdominal pain? Lower abdominal pain also is a symptom of having a deep vein thrombosis into the iliac veins. Why? Because often the thrombus extends into the pelvic vessels, and at the same time, the collaterals start to develop in order to make the tissue survive, which results in the pain. So over here, these three are the buzzwords. Moving on to pulmonary embolism. Whenever we think of pulmonary embolism, we are thinking of a patient who is dyspneic, who is out of breath. And of course, we're also thinking of a patient who has suddenly collapsed. But I want you to look at these highlighted points: chest pain, hemoptysis. These are the two buzzwords. If they are in the question along with dyspnea or along with a collapsed patient, we want you to keep a diagnosis of PE in mind. Okay, when you encounter such buzzwords in the question, I want you to keep in mind that such diagnosis of PE would also be possible. It can be myocardial infarction. Hemoptysis might mean tuberculosis, but you, when encounters these keywords in the question, you look at the options, maybe the question is pointing towards thromboembolism. Okay. So moving on, another important thing that we tend to overlook is that low-grade pyrexia and leukocytosis. Often when there is a very long question, many details are given. The temperature is such, the pulse rate is this, the patient has a cesarean, the BP is this, output is this, and there is a blood profile that is available where the WBC counts have shot up. And in the options, we are seeing that maybe the question is pointing to a VTE related question. So in order to confirm, you can always look at these two buzzwords, that is pyrexia, low-grade fever, that is not like a temperature of maybe 102, but a low-grade pyrexia along with leukocytosis can occur with VTE. These are all not directly asked as questions, but will help you solve a question for a clinical scenario. So now moving on, facts and numbers. Yes, unfortunately, we do need to deal with facts and numbers because part 2, there are a lot of percentages that are asked in the exam. If you've been with us in the last class, I had asked you all to actually make a notebook and in that notebook, jot down all the important numbers that you find during the session, that is, or during the entire course of preparation. That notebook will come in very handy the night before the exam, when all the concepts are driven home, when you just need to have a look through all the numbers so that if there is any repetitions from the known questions, we do not make a miss of an easy question. So in this particular guideline, 2 to 6 out of 100, that is 2 to 6% is an important number. Why? What is it denoting? Suppose there are 100 patients in whom we are thinking that the patient is having signs and symptoms of pulmonary embolism. Out of that, 2 to 6 will have a confirmed diagnosis of pulmonary embolism. Okay, so this is an important number from this guideline. Moving on, if DVT, that is deep vein thrombosis, remains untreated, then 15 to 24% will develop pulmonary embolism. So always remember that DVT is the main source of pulmonary embolism. Okay, embolus usually forms elsewhere in the deep veins, and then they move up to the lungs. And if a DVT is not treated, then 15 to 24%, that is about 1/4 of them, will develop pulmonary embolism. And PE during pregnancy is fatal in 15% of the patients. Okay. Along with that, you need to keep in mind that in all the patients where there is an unfortunate casualty, that there is mortality, of all those patients, 66% of these patients will expire within 30 minutes of the embolic event. This statement actually shows us how important it is for all of us to be very vigilant and very prompt in managing a case that we are suspecting to be a case of embolism, because about 66% patients will die within the first half an hour. Okay, so now we have moved on to a particular situation where we are discussing a very important algorithm from the guideline. I just want you to tell me if this is legible, if you can read the letters very clearly on the screen. Is it visible? Are we good to go? Well, hello, everybody. Yeah, I have the chat box buzzing. Okay, yes, Hanifa, Anus, Novia. I remember you all from the last class. Shaurya, were you there? I don't remember actually, but okay, good to have you all back. Okay, so we are good to go. Let's continue. If you ask me which is one important table in this particular guideline, which will kind of summarize the entire thing for you, that is this particular algorithm. You must be knowing. But then let's discuss. A patient comes with a suspected case of pulmonary embolism. We carry out a clinical assessment, and what the arrow highlights over here is that we perform a chest X-ray as well as an ECG. Okay. These two are very important preliminary investigations. You all know when we think of VTE, we are thinking of diagnosing by week. Hello? Yeah, somebody's unmute. Um, I think somebody unmuted themselves by accident. Okay, moving on. So chest X-ray and ECG, these are very important and vital in the preliminary investigations that we are conducting. We all know that when we think of VTE, we are thinking of VQ scan, we are thinking of CTPA, because the questions always come that way. But this is very important really, in order for you to note that this is one of the first line investigations, along with this routine bloods that we have discussed earlier also. Complete blood or full blood count, FBC, urea and electrolytes, as well as the liver function test need to be done. So preliminary blood investigations along with chest X-ray and ECG. And this line is very important. Commence LMWH unless treatment is contraindicated. If you have been with me in the last session, you would know that LMWH comes with a set of contraindications. But if there is no such contraindications, and if you have a case of suspected pulmonary embolism in mind, the first and foremost step for its treatment is start LMWH and then try confirming your diagnosis, but give the first shot to the patient. Now, suppose if the patient is having symptoms and signs of DVT, okay, look at the yellow part of the flowchart over here. Yes, the patient is having symptoms and signs of DVT. So the test of choice would be a compression Doppler ultrasound. Okay, the compression Doppler ultrasound will be a confirmatory test for DVT. Yes, it does confirm. Then we are continuing with the therapeutic dose of LMWH. We have given the patient a shot over here, and now we are continuing with that. All right. But suppose we have done an ultrasound, but no, we are not being able to visualize that there is a thrombus anywhere. Okay, the ultrasound is not picking up a thrombus. Then what do we do? Then we look at the level of suspicion. By level of suspicion, I mean, can the patient have any other condition other than DVT? Can there be any other cause leading to such a presenting scenario for the patient? Suppose no, we are thinking of nothing else but DVT. That is, our level of suspicion is high. We will stop LMWH, but we will also do a repeat ultrasound on day 3 and day 7, because maybe initially it is not picking up, maybe later it will actually pick up the thrombus. But all the while we are actually stopping LMWH. If the level of suspicion is low, like maybe the patient has pulmonary, is not having DVT, maybe there is some other explanation for this, then we will stop LMWH and we do nothing else. Okay, we treat her according to the next diagnosis that we have in mind, right? Up to this, is this clear to everybody? Do we have any questions so far? Okay, moving on. Suppose if there is no symptoms and signs of DVT, but then we need to know if the chest X-ray is normal. Then we are looking at the chest X-ray. If the chest X-ray is telling, look at the blue pathway here, that no, it is not normal, then we are going to carry out a CTPA. Okay, that is CT pulmonary angiography. And then if the pulmonary embolism is confirmed, then we carry out further. But if the chest X-ray is normal, then we will perform a VQ scan. Now, this is an area where a lot of questions actually do come. Okay, if the VQ scan is normal, if the chest X-ray is normal, I'm sorry, then we perform a VQ scan. So how do we remember under the stress of the exam, on the day of the exam? So that we don't confuse, we have a mnemonic in mind. That is vein. Vein, V for VQ scan and N for normal chest X-ray. All right. So always have this mnemonic in mind. Vein, V is VQ scan, and normal chest X-ray. So whenever the chest X-ray is normal, we do a VQ scan. If it is abnormal, that is if you are finding certain findings, then we go for a CTPA. Now, either by VQ scan or by CTPA, we have come across a pulmonary embolism. Okay, so the diagnosis is confirmed with us. Then, yes, if it is confirmed, very well, we will continue with therapeutic LMWH, as you can see. But if no, if it is not confirmed, then we will again move on the basis of our clinical suspicion of pulmonary embolism. That is whether any other diagnosis is maybe satisfying our patient's symptoms. So if the clinical suspicion is low, we will discontinue LMWH and consider the alternative diagnosis. But if the suspicion is high, we will consider alternative or repeat testing and continue LMWH. Okay. So here, if the suspicion is low, we will discontinue LMWH. And if the suspicion is high, we will continue LMWH. All right. So from DVT to PE, at this particular point, this is the only point of difference that I would like to highlight. For DVT, no matter the level of suspicion is high or low, we are stopping LMWH. But for pulmonary embolism, because it is more fatal, because it is already in the lungs, if our suspicion is high and we have not come across a confirmation in any of our diagnostic tests, we will continue with LMWH unless we come across an alternative diagnosis anywhere. So is this clear, or do we have any questions so far? I just want you all to be responsive in the chat box or unmute yourselves. Okay, clear. Good to go. Right. So now we will be having a look at the basic investigations. Now, chest X-ray. Whenever we talk of chest X-ray and we are thinking of a patient with pregnancy, the first and foremost thing that comes in our mind is, well, no, she's pregnant. We cannot have a chest X-ray done to her. But no, actually RCOG confirms through a lot of meta-analysis that we know that the amount of radiation to the fetus actually is negligible. Okay. So the radiation dose to the fetus from a chest X-ray at any stage is negligible. That is less than 0.01 millisievert. All right. Other than that, we need to know how much confirmatory is chest X-ray. Whether it is a very good test, it's not. It's one of the basics. Why? Because it might be normal in over half of the patients with PE. So we never know for sure. All right. So if across we come across one of these particular findings in PE, that can be atelectasis, effusion, focal opacities, regional oligemia. By that, we mean that there is reduced supply in one of the regions in the X-ray, that is the bronchovascular markings that we have on the X-ray, and pulmonary edema. All right. Okay. Follow up after discontinuation of PE. Okay. Yeah, we are coming. We are coming. There are a lot of slides, a lot of things to be discussed. So let's just continue with that. Here, I'm just explaining about all the investigations and all the important facts that you need to know related to the investigations, if any SBA comes from that. Okay. Now, moving on. ECG. ECG is abnormal in only 41% of patients with PE. Okay, so remember this number, this particular number is important for us. What are the features? What are the features in ECG? And this might come as a question, okay? In one of the SBAs, this might come as a question. This, what are the features? T-wave inversion is the most common, 21%. S1Q3 T3 pattern, that is about in 15%. And right bundle branch block, it might occur 18% during pregnancy, 4.2% during puerperium. Okay. I know too much of learning of these numbers would be difficult. I would want you to focus on this 21% and 15%. And I, of course, need you to know T-wave inversion, S1Q3 T3 pattern, and RBB. These are the features that we find in the abnormal ECG. All right. Now, this is very important as a chart. Many questions might come from this one particular comparison that we're going to discuss. So I need you all to be really focused on this one. VQ scan and CTPA. Which one to choose and what are the merits and demerits? That is the advantages and disadvantages. Now, you can see that VQ scan have got a star to itself. Okay, means okay, we have a question YT inversion with PE. YT inversion with PE, well, it's a bit difficult for me to explain that way because you may be thinking that it is associated with myocardial infarction, okay? But in the particular lead 3, if we find T inversion, then it is suggestive of PE. That is what the findings go so far, okay? So with VQ scan, we will have high negative predictive value. That is, out of the two, higher negative predictive value is VQ scan. Means if a VQ scan is telling us that no, the patient does not have embolism, we are not finding anything suggestive in the scan, then we can be sure, all right? And also low radiation to breast. This is very important, okay? Having discussed these 2 points, first I'll be moving over to CTPA and look at the points that we have on this side of the table, okay? CTPA is identifying other lung lesions. Like it will also tell you if the patient has any other lung problems other than embolism, okay? So, well, this is a good proposition. Low radiation to fetus, 0.1 milligray, lesser risk of childhood cancer. Yes, this is also sounding good. Okay, 20 to 100 times higher radiation to breast than VQ scan, which leads to breast cancer, increases the risk by 13.6%. Okay, I need you all to remember this percentage, 13.6% increase in breast cancer with CTPA. All right. So if CTPA is having lower radiation than VQ scan, then why are we putting the star over VQ scan? Why are we choosing VQ scan? Okay. Because VQ scan has low radiation to breast. When we compare between VQ scan and CTPA, VQ scan is having lower radiation to breast and breast risk of cancer thereafter. Okay. About the radiation to the fetus, we know that VQ scan is having more radiation when compared to CTPA, but we can omit ventilation component to minimize radiation to the fetus. So with this part also we can help. It also has low radiation to breast. It also has a high negative predictive value. So if it is asked in the question that what is actually the test of choice, in this case, we will say in pregnancy, we go for a VQ scan. All right. Now, ventilation component, perfusion component, I think you know, but just to have a quick recap, V is for ventilation component and Q is for perfusion component. Okay. We always need to look at the perfusion component. That is non-negotiable in case of a VQ scan, but the ventilation component or the V component, we can omit and thus reduce radiation. All right. So moving on. Okay. So here we have again come across a particular chart. Maybe you are not very happy seeing such, elaborate numbers, but let's make it easier. Okay. This is referring to LMWH therapy that we are giving to the patient who is coming to us with VTE. All right. In VTE, we can either give the patient LMWH or we can give unfractionated heparin. Out of LMWH, we have got enoxaparin, dalteparin, tinzaparin. Okay. These three names we have also come across when we were discussing the prevention guideline, GTG 37A. Now, unfractionated heparin is something new that we are considering in this particular management guideline. Am I clear? All right. So, enoxaparin or Clexane dosage. How are we going to? Okay, why comparison between VQ and CTPA, and every investigation has its indication. Okay, I get that. Why I made this comparative picture, it's not going to be asked like this, a comparative question, but when we discuss a comparative scenario, things are registered better. The questions will come differently. The questions will come like, which of these investigations is having more risk of childhood cancer? Which is the investigation of choice maybe? Which is the investigation of choice we have when we have a normal chest X-ray? Which is the investigation of choice when we have an abnormal chest X-ray? Which is the investigation where there is increased risk of breast cancer? What is the percentage? That percentage is also getting important because that might be asked in question. That is 13.6% increase in the risk of breast cancer. So that is why I prepared a chart where there is a comparison. Nobody will ask you that enumerate the differences between CTPA, VQ scan, but it is just for your ease of learning and keeping it in mind during the exam so that you can answer all the questions. All right. Okay. So now, moving on, it is booking or early pregnancy weight, based on which we are going to calculate the LMWH dosage. All right. So if it is less than 50 kgs, then it has to be 40 milligram where we are starting. If you remember our prevention guideline, we were starting at 20, but because it's a treatment dosage, we are taking 40 milligram twice a day, or 60 milligram once a day, all right, for less than 50. From that, we can work out the chart ourselves in the exam. How? By adding 20. If we add 20 more units, then 50 to 69, over here we add 20, 60 milligram BD, or for this we have adding 30, that is 90. So 60, 90, 120, 150, 180. Over here, 40, 60, 80, 100, 120. And 50, 50 to 70, 70 to 90, 90 to 110. Like this, we carry out till 125. If it is more than 125 kilogram, then a hematologist opinion needs to be sought. Okay. One important point, question might come, have not come so far, but might come. So keep it in mind that creatinine clearance needs to be less than 30 ml per minute when we are given enoxaparin in this particular treatment dosage. Okay. And for the dosing, we also have 1.5 milligram per kg once daily, or 1 milligram per kg twice daily. This kind of simplifies the things for us. If you note this particular number, suppose we are having a patient with 60 kg, then 60 milligram, that is 1 milligram per kg twice daily, 60 milligram BD, or 1.5 milligram per kg once daily, that is 90 milligram once daily. This is how we can work with this formula, or we can work out the chart by adding these numbers in this way. Okay. Now, moving on, we would have another particular chart where we are going to deal with where we are going to come across Deltaparin. Deltaparin or Fragmin. Fragmin is actually the commercial name that we have in place of Deltaparin. Okay. For Deltaparin, again, creatinine clearance needs to be less than 30 ml per minute. Dose is 100 IU per kg twice daily. All right. Over here, the weight category remains the same. Okay. We go on adding 20 units. All right. And over here, we are starting with 5,000. and increasing by 1,000 units. Over here, we are increasing by 2,000 units. The first one is by 1,000, second one is by 2,000, and then we are continuing with 2,000. That is for the BD dosing. For OD dosing, we are just multiplying the BD dose. That is, if it is 5,000, we are giving 10,000, 6,000, then it is 12,000. Now, having said that, I know it will be difficult to memorize all these charts. I have not encountered a question for Deltaparin or fragment dosage with in respect to treatment of VTE, but either try to work it out this way or maybe work it out from this particular table, okay, in order to solve questions, if at all they come in exam. Now, moving forward, we have another aspect, another particular LMWH that we need to discuss, that is Tinzaparin. Tinzaparin or InoHep is to be given about 175 international unit per kg once daily. All right. And over here, I need you all to note that the creatinine clearance needs to be less than 20 ml per minute. For the previous two, it was 30 ml per minute, but over here, creatinine clearance needs to be less than 20 ml per minute. All right. Now we have come to one of the important aspects of this particular guideline is the target levels. I think you were asking how to follow up, how to, monitor. Somebody was asking in the chat box. So it is all about maintaining the target levels. Now, if you see target levels, we are seeing the peak after 4 hours, peak 4-hourly levels we are monitoring. I want you to see over here that we have anti-10A level, which is 0.5 to 1 IU per ml, APTT, which is 1.5 to 2.5 IU per ml. Now, these two become very important as far as our, the guideline is important. INR, I have made a note. INR is not that important because all the aspects will be dealt with on the basis of anti-10A level or APTT. Commonly, questions come from these two. INR level, the target range would be 2 to 3 per IU per ml. I think this is more relevant in our clinical scenario day to day, but these are the more important areas which we need to focus on in order to solve questions, okay? So for anti-10A level, routine anti-10A levels are not done unless if the patient is underweight, that is body weight is under 50 kgs. If the body weight is at 90 kgs or more than 90 kgs, then also anti-10A levels are routinely, need to be done. And of course, if the patient has comorbidities like a renal condition or recurrent VTE. So if you with me in the previous session, the prevention session, I had asked that monitoring is important. We had a slide. For unfractionated heparin, it is platelets. And also about anti-10A levels, we monitor in therapeutic LMWH, not in the prevention part, and also in the therapeutic aspect also, when you are given a patient therapeutic LMWH, we routinely do not monitor, we monitor in this particular situations. Okay. Okay, my question about follow-up, if decide to stop LMWH in PE, okay, when do we decide to stop LMWH in PE? That is also there, just be with us. We will be discussing that shortly. Okay. So routine anti-10A level is not done unless these are the particular points that we have discussed. Okay. So moving on, if I focus on this particular chart, APTT, this is a story that is waiting to be told. Okay. We will come to this APTT levels later. And before that, I would like to have you all focus on this particular aspect, that is massive life-threatening PE. What is massive or life-threatening PE? Suppose a patient has come to us with dyspnea and the patient has collapsed. Always, 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 whenever there's a question related to this, It will be a presentation in the accident and emergency unit of the hospital. The patient has come, the patient has collapsed. If you have read the maternal collapse guideline, it will be a similar kind of a clinical presentation. So if we are thinking of a diagnosis of PE, what need to be done stepwise? First of all, if it is a collapsed patient, the first and foremost step would be resuscitation by ABC, that is airway, breathing, and circulation. All right. Along with that, when we are thinking about massive pulmonary embolism, because it is so severe and serious that we might lose the patient within 30 minutes, the first and foremost step is the star mark step that we have over here. Unfractionated heparin, 80 unit per kg bolus dose, followed by 18 units per kg per hour maintenance dose. All right. So up to this, is it clear? These are the first very basic steps. Either or will be asked as what would be the initial step of management. If there is a question giving a clinical scenario, we have discussed a similar question from Get Through EMQ book in our last session in the prevention guideline, where if suppose they're telling that the patient has come with massive pulmonary embolism, they won't mention that massive pulmonary embolism. They will give you the PE picture and they will say collapsed. Then we will do a resuscitation, ABC. If they are not mentioning a collapsed patient, but it's mentioning that there is a presentation and the patient is now stable, then we go with unfractionated heparin. Exactly the question which we had discussed in our last session. Okay. So what is the dosage? This number is 80 and 18. I think it is a bit easier to remember on our part. So please try and remember 80 is the bolus and then 18 would be the maintenance dose. Now, who all would be involved in the management? Communication with colleagues is a domain for MRCOG Part 3. Who all we are involving is also very important. That is a very important domain for Part 3 students as well. Maybe not so much for us in Part 2, but it's very important in Part 3. So multidisciplinary team would involve the senior obstetricians, the physicians, and the radiologists. Okay. Along with that, a CTVS surgeon, that is cardiothoracic vascular surgeon, might be involved in certain scenarios. What are those scenarios? We'll come to that later. Okay, CTPA or portable echo needs to be done within an hour of presentation in the ER. All right. Now we have resuscitated the patient. We have commenced with UFH. We have involved all the team. We have done the investigations, and then we also need to measure APTT, which I was talking about, the target levels and when to measure APTT. Now, APTT measuring always is synced with whenever there is APTT, it is pointing towards unfractionated heparin. That is, we monitor APTT for unfractionated heparin cases. Why do we measure APTT? Because the patient has collapsed or the patient is having a massive pulmonary embolism. The embolus is a clot, and we need to know whether we are giving enough unfractionated heparin to dissolve the clot. All right, whether the dose is being proper with us or not, or we need to give a rebolus dose, or we need to up this maintenance dose, is why we are looking at the APTT levels. So we have given the loading dose. How much it has worked will be reflected with the measuring the APTT. So we will be measuring it 4 to 6 hours after the loading dose. All right. Suppose we are not happy, we are upping the dose, or maybe we are, reducing the dose. Then 6 hours after any dose change, we will again measure APTT. And suppose we have now stabilized the dosage schedule. We are happy with the way things are with this patient, and we are continuing on the same unfractionated heparin dosing. Then we will do it daily to see if it is in target range. All right. So measuring APTT, these are the points that we need to keep in mind. Now, what is the final management plan? The final management plan will differ from case to case basis. What we are aiming to do for the patient is to dissolve the clot. Dissolving the clot might happen only with the unfractionated heparin. Maybe this will be enough, IV UFH. Maybe that won't be enough and we need a thrombolytic therapy for the patient. Okay. if there is a clot that is not responding well with UFH. All right. Okay. And thoracotomy. Thoracotomy is a particular situation where we have to involve the CTPA surgeon. What I had, just told you earlier, that certain situations where in MDT, we will be involving one of the seniors would be by thoracotomy or surgical embolectomy. These are the situations where we actually involve CTPAs. I think there's a question, massive PE with collapse. Okay. And there is also PPH to make your life worse. Okay. Then what would be the plan? Then, of course, we are not thinking of unfractionated heparin, okay, because that will further aggravate your situation. Resuscitation. And then I think we are answering your question over here. We will have to move on with either thrombolytic therapy, thoracotomy, surgical embolectomy, and of course, management of PPH will follow like it follows. Okay, the flowchart for management of PPH will be done, but we have to then resort to any other type of therapy, and the multidisciplinary team also needs to be involved. However, such questions I have not come across, but okay, if they ask you, then in the flowchart, the first thing I need, I discussed that commencing anticoagulation therapy, we need to look at the contraindication. Of course, if there is PPH, that is one of the contraindications. So of course, we won't be doing with LMWH, but we will carry on resuscitation and with similar other situations like, all the other modalities that we have. But such a clinical scenario, a patient having embolism along with PPH is quite, related to a lot of, wishful thinking. And normally a patient has embolism on one hand, and then there is PPH also is not likely. But then moving on, I will be discussing about, that is the individualized management plan. What we will have is IV unfractionated heparin, which we know we will manage, thrombolytic therapy that I'll be discussing in the upcoming slides. Thoracotomy and surgical embolectomy is not something that needs a lot of discussion. Just remember that if we are planning for this, we need to involve the cardiothoracic vascular surgeon, and as it's an operative therapy. Okay, now, if you're treating with IV unfractionated heparin, what to do? And what do we do for thrombolytic therapy? Now, as far as our questions come in exams, there had not been many questions, or that in my experience from thrombolytic therapy, there had been questions from unfractionated heparin. So I would consider that this is important. This you also need to know. All right. So moving on. Now the patient has come, the patient has collapsed. Okay, why unlikely to occur? That is a patient with PE and a patient with PPH. Well, when a patient is having an embolism, that is the patient is having, okay, PE leading to DIC, and then the patient is starting to have PPH. Now, PE leading to DIC, whenever a patient is having a DIC, that is would be like, for a long time, a problem is having or occurring with the patient. So whenever the patient is having PE, the patient is presenting to us, or maybe the patient is presenting to us, and then we have already started treating her for PE, and then all the sequences start developing with the patient. Okay, so maybe in such a situation we can explain, but it's definitely one of the unlikely situations that we come across, right? So does it answer your question, or do you need to unmute yourself and let's have a clarification? Or we can move on with our presentation. Just give me a heads up for that. Are we good to go on that one, or do we, okay, okay. Okay, so moving ahead, about IV unfractionated heparin. Okay, about IV unfractionated heparin. Now we have put the patient on unfractionated heparin, and as I was telling that we need to measure APTT. Why? Because we need to know whether we have satisfactorily thrombolized the patient enough or not. Okay. So this is another chart. When we look at it at a glance, it seems impossible that we can remember all these numbers, but let's break it down and make it easier for us. Just understand, let's understand this chart together. First of all, what we are looking at, APTT. By looking at APTT, what do we need to do? We need to change the dose. The dose of, whenever you're telling units per kg per hour, that is the maintenance dose, okay? What would be the additional action? Additional action might be a rebolus or maybe stopping the infusion. All right. And when do we next again measure the APTT? Okay. So first and foremost, what was our target range? We will start our chart from here. Target range was 1.5 to 2.5 for APTT. If we are at particular this target range, then okay, we are not giving any other changes. We are continuing as it is with our dosing. So if there is no further change, what do? We measure the APTT again after 24 hours. You remember this particular slide? Daily to keep in target range. So this is what we are talking about. Target range has been achieved. We will measure now daily to keep in target range. Okay. Now, if the APTT is 1.2 to 1.5, that is, the blood is a bit thicker than we are going to be happy with. So in such a situation, what do? We will have a dose change. We will up the dose by +2. That is the maintenance dose. And we will also give the patient a rebolus of 40 units per kg. Now, whenever there is a dose change, 6 hours after any dose change, all right? So over here, the next APTT recording that we are going to take would be after 6 hours. All right, okay. Suppose APTT is less than 1.2. That is, we still need to give more and more anticoagulation. We are not happy with the situation. Then the dose change has to be by 4 more units. That is, suppose we were at 18, then we have added +2. Then we are finding that the APTT is 1.1. Then we will further add +4 units to it. Okay. And also we will give a rebolus of 80 units per kg. And again, we will measure the next APTT 6 hours later. Okay. Now suppose 1.5 to 2.5 is the target range. And we are finding that we have thrombolized the patient so much that the APTT range is 2.5 to 3.0. Now, we don't want that to be happening either. We don't want to, give too much of anticoagulation therapy to a mother who has delivered or is about to deliver, or in any situation, even if not about a delivery also. In any situation, we do not want to make the blood too thin so that there is no other further hemorrhages happening in the brain or anywhere else. So now we need a dose change. Now we need to reduce the dose by -2. Suppose we were at 18, then we need to go back to 16. And do we give a rebolus? No, of course, because we now are, trying to give her less and less of anticoagulation. So we don't need a dose change in terms of giving any additional action like a rebolus dose or anything. And then again, when do we check her APTT? 6 hours later, because 6 hours is the time from a dose change when we do check the APTT again to see if we are at satisfactory level. All right. If we have given her so much so of anticoagulation that the level has gone up by more than 3, in such a situation, we will do a dose change, and then we will be decreasing the dose change by -3. And also we will stop infusion for 1 hour and then again check 6 hours later. All right. So this is a chart we need to work our way around like this. Always start from 1.5 to 2.5. And remember, over here we are moving by 0.3. Over here we're moving by 0.5. And just as at a glance, try to remember how we are changing the maintenance dose, how we are adjusting the bolus dose. And I think this is easy to remember, this part at least. All right. So we are done with one of the confusing charts of the GTG 37B. Now, as discussed, IV UFH, we have considerably done a long portion of it. Okay. What dose to initiate, how to go about monitoring. Now about thrombolytic therapy. Thrombolytic therapy for a massive pulmonary embolism. Now, questions have not been asked, but it mentions in the guideline that these are the particular agents. You just remember the names, which we usually suggest when we consider the patient for thrombolytic therapy. Streptokinase, urokinase, RTPA, alteplase, and tenecteplase. Okay? Okay. So just to sum it up, for treatment of VTE, if it is a pulmonary embolism or DVT, and it is not something where the patient has collapsed or not of that great a magnitude, we will start with LMWH. That is enoxaparin, Deltaparin, Benzaparin, all those that come into play over there. But if it is a massive PE and the patient has collapsed, then we will go straight forward to unfractionated heparin, the dosage chart that we have seen, how to up it, how to take it down, and to monitor with APTT. For LMWH, we monitor with anti-10A. All right? Okay. So far, we are clear on this? Okay. Okay. So I think you were asking about this question, how to follow up with anticoagulation for VTE. So I think this was the question which we were asking. And suppose there is a VTE event in pregnancy with a patient. First, look at this particular point. Suppose the patient is 22 weeks pregnant and she suffered from pulmonary embolism or DVT. So we continue with the therapeutic dose of treatment, that is LMWH, for the rest of the pregnancy and of course 6 weeks after delivery. Are we clear on this? Okay. So this is the duration and the dose is therapeutic dose. Now I want you all to focus on this particular point. At least 3 months of treatment in total. Why I am saying this? Suppose if a patient comes to us at 36 weeks of pregnancy, she has a pulmonary embolism. All right. And immediately we have carried out her with anticoagulation therapy. Now, for this patient, how long do we continue? Maybe at 37 weeks herself she delivers. And then 6 weeks postnatally. That is, she is receiving therapy about for 7 weeks. So do we stop after 7 weeks for this patient who has come to us at 36 weeks of gestation with pulmonary embolism? Do we? Well, we do not. We have to give at least 3 months of treatment in total to the patient. All right. Are we clear on this particular aspect? How long do we continue? It has to be total pregnancy with 6 weeks postnatally, but it also needs to be at least 3 months of treatment with therapeutic dose in total. Okay, yeah, I'll be repeating. Okay. So how long do we continue with LMWH? Suppose Mrs. A has come to us at 22 weeks with DVT. Okay. So we have diagnosed, we have treated her with therapeutic dose. The dosage is therapeutic dose. Now, from 22 weeks, what do we do? How do we manage her further? We continue with therapeutic dose all through her pregnancy. From 22 weeks till she delivers. Suppose she delivers at 39 weeks. After she delivers, what do? We still continue with therapeutic dose, okay? We are not going back to prophylactic dose. We are continuing with therapeutic dose. How long? Her entire puerperium, that is 6 weeks postnatally. All right. This was one scenario. Now, suppose there is another patient, Mrs. B. Mrs. B comes with DVT, but at 36 weeks of pregnancy. Okay. Now, at 36 weeks of pregnancy, she has DVT. We have started her on therapeutic dose of enoxaparin. Suppose she delivers at 38 weeks on her own. Okay. She delivers at 38 weeks. So for 2 weeks, she had received treatment. Then after she delivers, we are continuing 6 weeks postnatal. So 2 weeks plus 6 weeks. She is receiving 8 weeks of treatment in total. All right. But do we stop after that? No, because 8 weeks means 2 months. But at least we have to continue the treatment for 3 months in total. Okay. So 3 months of treatment with therapeutic dose is necessary for a patient when she comes with VTE. So this is good whenever a patient presents in her early pregnancy. If she is coming in the later part of the pregnancy, or maybe she has developed embolism just after delivering the baby, or maybe, just a few weeks ahead of a delivery, then we continue with therapeutic dose for 3 months in total. See, if you're not clear, we can also repeat and have this point clarified. Okay. I just need you to know. I just want you to tell me. Okay. We are clear, everybody. Okay. So I think we can move on from here. Okay. Now we are coming to relatively easy, easier parts. Okay. Additional therapy. Okay. What could be the additional therapy? Graduated compression stocking in DVT. What will be the pressure? Suppose a patient already has DVT. In this particular case, what would be the pressure? That would be 23 millimeter of mercury. Okay. It will be applied to both the legs or one leg. It will be applied to one leg, that particular leg which is affected by DVT. All right. What else do we do with the leg? We will keep the leg elevated. And what else? We encourage the patient to get mobilized with the compression stocking on. Okay, so this is one additional therapy. 1 or 2 SDAs might come out of it. So it is important that we know about it. Another additional therapy from where we expect, bits and pieces of question would be the Kava filters. Okay. The Kava filters, I think when we were solving questions from Get Through book in our, previous session, we have had a question from that, and I have seen that all of you have responded very promptly that Kava filters need to be, used in recurrent VTE. Yes, we know that. What also we need to know a little bit of facts as well, which is recurrence of VTE occurs usually within 2 weeks of initial event. Okay, not that it cannot occur later, it can, but most commonly within 2 weeks of the initial event, we might have a case of recurrence. This is just a factual, information that you need to keep in mind. And we have placed the Kava filter. Suppose a patient has, stenting of one of the coronary arteries. What do? We leave the stent forever there. Suppose there is a Mirena insertion. We take it out after a certain time. So have you wondered what do we do about the Kava filters? We keep it inside for long, or do we take it out later? So this answers your question. These filters need to be removed after 2 months of delivery. Okay, so these are the facts which I think are important to know about Kava filters. Now, D-dimer testing. Suppose you are dealing with VTE such scenarios outside the context of pregnancy, that is in the non-pregnant population. Then we always come across this particular test, D-dimer testing. But is it important in pregnancy? It is not recommended. Why? Because the values will already be elevated in pregnancy. As a lady goes near term in her pregnancy, the D-dimer levels increase, and it is not a good indicator to test in pregnancy. So D-dimer and pregnancy, it's a definite red cross. What else is a red cross? Pre-test probability. In many books as well, maybe you have read about Wells score, about modified Wells score, and about the left rule. That is, the left leg, and in the first trimester, if there is edema. So left rule is actually the left leg, which stands for L, E for edema, and the first trimester. There is also a rule about that. Nowhere a question has come so far, but just in order to make you, understand what are the pre-test probabilities, these are the pre-test probabilities. These are basically scoring mechanisms which are mentioned in the guideline, which have good predictive value. If you see, they do have good predictive value, but RCOG does not recommend using these particular scoring methods to diagnose a case of VTE. So as far as our attempting questions in RCOG examination goes, we would not suggest this particular tests to be done. Okay. What they say, actually, the guideline, that these scores are very good predictive rate and everything, but further trials, on a bigger population needs to be applied before actually RCOG takes them in consideration to be used in their screening mechanism. Okay. So thrombophilia screen. Thrombophilia screen is not recommended in pregnancy. Why? Because thrombophilia screening is actually looking at protein C, protein S, antithrombins, all those factors. And if you remember the coagulation factors, they all go up and down in pregnancy. Okay, some proteins go up, some proteins go down. And so pregnancy is not a good time when we test or screen the patient for having thrombophilia or not. We do that after the pregnancy is over. Same goes for APLA. Okay, we do not test when the patient is pregnant, we test her later. Okay, if you remember, last time we had a dose timing slide where there were the three numbers, 24, 12, and 6, as to when do we give a regional anesthesia or remove a catheter. Over here, we have a similar dose timing, scenario, this time related to unfractionated heparin. Okay, so unfractionated heparin can be given to a patient in a subcutaneous way or in an intravenous infusion. The guideline mentions that if you have given the patient a subcutaneous unfractionated heparin, then before you give the patient regional anesthesia, it has to be at least a 12 hours gap. If the patient has received the same treatment in IV route, then at least 6 hours before regional anesthesia. These are the 2 points that has been mentioned in the guideline, which is worth noting. However, I have not recently seen any questions coming from these dose timings. The dose timings which are important for VTE is mainly with LMWH and the prevention of VTE. Okay, but these points are there in GTG 37B, so it's worth mentioning over here. Okay, now I need you all to be a bit more active, please. This is the quiz time that I'm talking about, and there will be a lot of questions. And please be active in the chat box. You can also unmute yourself, but let's solve the questions together. So please give me a heads up. This much I need. I need you to be active in the chat box and tell me whether we are good to carry out the first question. Okay? Okay, okay, Malak. Yeah, I remember you from the last session, I think. Okay. So, yes, okay. All right. What is the target APTT to carry out cesarean section? Okay. In order to carry out a cesarean section, we do not do that by, measuring a target APTT. For cesarean section, there are two particular aspects that we need to, take in mind. That is, whenever we are giving, why do we measure APTT? We are basically seeing whether she has received anticoagulation and whether she is thrombolized enough or not. While we are considering a cesarean section, there are two aspects. The patient, while receiving regional anesthesia, might bleed into the spinal cord and have a spinal hematoma, which is one of the dreadful situations, or we are carrying out a CS, and it is us, our surgeon's nightmare, when we are not being able to stop the bleeding. Okay. So we do not monitor any target APTT for that. We have those timelines which have been provided to us in guidelines, that from so and so situations, from so and so duration of giving a prophylactic or a therapeutic LMWH or unfractionated heparin, we cannot prick the spine. First, we are dealing with regional anesthesia fact. Then I'll come to the other part of the question, is carrying out a cesarean section, that is the suturing, and what if she bleeds. Okay. So first we are thinking about what if she bleeds during the spinal and having a spinal hematoma that is potentially life-threatening. So for a patient who has received prophylactic LMWH, we have to wait for 12 hours before we can prick the spine. A situation has come, we cannot prick the spine, we cannot wait for 12 hours, then we will proceed with general anesthesia. Okay. Next is that about therapeutic LMWH. Then we have to wait for 24 hours, okay, from the therapeutic dose before we can actually put her in for a spinal anesthesia. We cannot wait for 24 hours. Such is the obstetric scenario. Okay, we proceed with general anesthesia. All right. Suppose it is unfractionated heparin. Okay, she has received by subcutaneous dose. Then we will wait for 12 hours if it is subcutaneous and 6 hours if it is IV for spinal anesthesia. We cannot have that much time, time duration. We have to carry it out immediately. Then always go for general anesthesia. Don't prick the spine. Avoid spinal hematoma. But the next thing is that what if the cesarean section, what about when we are taking the bites and she is bleeding? Now, if there is such a scenario, then we have to carry forward with the cesarean section, but there are certain changes that we need to make in our surgical techniques. That is what the GTG mentions. Okay. The GTG mentions that we will go with interrupted suturing of the skin, so that any kind of hematoma which will collect in such a situation, that can drain out. And also at every level, rectus sheath, below it in the in the peritoneal drain, and also over the rectus sheath we leave a drain, so that whatever collection is going to be accumulated there, that drains out. But if you ask whether there is any target level that RCOG has determined in terms of APTT, that we have to have this much APTT before we take the patient up for CS, then there is no such target level. What we do in practical scenarios is we carry forward with the cesarean section, and the hematologist manages by transfusing with the required elements. Okay. Also, another thing, if suppose the patient has been thrombolized too much with unfractionated heparin has got another benefit, protamine sulfate, which is a particular antagonist. We can consider giving that particular antagonist to help us during such a situation, but that is not the gynecologist's call. That is a multidisciplinary decision which the hematologist needs to be involved in. Okay. Okay. If urgent CS and not reaching target, see, a cesarean section is important, urgent for saving the mother and the child. The target is not reached. We continue with that. And what do? We put in the drains so that whatever collection will come, it won't get accumulated, leading to infection. It will drain out. That is the change in our surgical technique, which the GTG mentions. We do not give regional anesthesia. We will rather give her general anesthesia. All right. And we will involve the hematologist to put on all those, additional therapies, the blood components, which will help us with coagulation. But if you ask if there is a particular APTT mentioned, there is no such APTT recommendation. Okay. If we have to go for a CS, we go for a CS like this, making such changes to our surgical techniques. All right. So yeah, we had a long discussion. Now we can move ahead with our first question. Okay. So the first question is kind of a bit of a factual question that I have. If you've gone through the guideline, I think you'll be able to answer. If not, at least I'll encourage some amount of guessing. Okay. So what percentage of post-DVT cases of pregnancy has PTVS? Now, what is PTVS? PTVS is post-thrombotic venous syndrome. That is, after DVT, there are certain skin changes in the particular leg that is getting affected. Okay. Okay. Yeah. I'm really happy. I'm really happy with Sabah, with Umu, with Snovia. Yeah, you all got it correct. Can see screen or can't see screen? Is it okay? Okay. Okay. So yeah, all of you are right. Okay. Okay. Uh, is there an issue, Dr. Samina? Can you see the screen right now? Can you see the question? You can unmute maybe and give me a confirmation or in the chat box. Now I can. Okay. Then we are good to go. Okay. So what percentage of DVT? I have got 3 students who had come up with the correct answer. Okay. So it is 42%. Okay. So what is post-thrombotic venous syndrome? It results in inflammation, calf swelling, discoloration, eczema over the thrombosed area where the underlying thrombus is. Over that, there is all these skin changes which happen. And just a high-yielding fact for you all to know, does graduated compression stocking, do they help with such a situation? Well, they do not. If this kind of skin changes is to happen, they will happen. And how frequently do they happen? They happen in 42% of the case scenarios. All right. So moving on with this particular question, this was discussed in our previous session. And I want you all to answer this one correctly. Patient with unfractionated heparin should have platelet count monitored how frequently? Okay. Yeah. I'm so happy. I'm so happy. Yeah. Sabah, Malak, Snovia, Dr. Samina. Yeah, you are all correct. Every 2 to 3 days from days 4 to 14 or until heparin is stopped. Now, why did I put this question? I put this question because actually this part, every 2 to 3 days from days 4 to 14, this part we all remember. What we don't remember usually is or until heparin is stopped. Okay, because like in MRCOG therapy for eclampsia, what all we have seen that it has to be 24 hours from the last dose when we stop or after the last seizure. Similarly, here every 2 to 3 days from days 4 to 14 or until heparin is stopped. So that is why I put this question, because when you solve questions, all these minute points make more significance, and you tend to note these points more. Okay. So, okay. This is a question that I have in general for you. Maybe answer in a yes or no. This is not an SB or an EMQ, but maybe answer in a yes or no. Can we use vitamin K antagonist in puerperium? Why I framed this question is basically I want you all to remember what are the vitamin K antagonists that I'm talking about. Okay, yeah. Sabah, really happy. Warfarin, yes. No, Snovia, given the correct answer. Dr. Samina, Malak, okay. Yeah. Everybody had given the correct answer. Vitamin K antagonist is warfarin, and of course, we know that we can use that in puerperium. Okay. Moving on to our next question. Okay. A 21-year-old woman at day 3 post-delivery developed acute shortness of breath, tachypnea, tachycardia, hypotension, and chest pain. You remember how I highlighted chest pain was one of the buzzwords? So yeah, shortness of breath and chest pain. Okay, but This question is kind to us. It has already told us that the CT angiogram revealed massive pulmonary embolism and decision of thoracotomy taken. Okay, so what would you advise? Now, this was a question which has been lifted from one of the EMQs. So I think you can kind of make out from the options by, ruling out the options, you can come at the correct answer. Okay, it's a big question. I'll go silent now, have a reading, and then answer in the chat box. Okay, finally we have an answer. I don't get the question. Okay, okay. I was happy to seeing the chat box, light up, but okay. I don't get the question. Is not I was expecting. Okay, D. Do you mean in next pregnancy? No, actually, this question was lifted from one of the EMQs. That is why you're having a bit of a trouble comprehending the question. No, it's not the advice for the next pregnancy. It is, see, the patient has delivered. Post-delivery, she has got chest pain and hypotension and all that. So post-delivery, basically, she has pulmonary embolism. Now, what is her advice? CS under GA, CS under SA. Yeah, these are actually questions from an EMQ. So these options are there. These options are now, not relevant for this particular question. So these two options are out of the way. Now, aspirin in prophylactic LMWH during antenatal period. During the antenatal period, well, no, that is also not recommended, because why would we recommend, aspirin has got no role as far as, all these embolism situations are concerned. You remember from the last slide, last class, what we discussed, one of the big red cross mark. Okay, now it's therapeutic. See, we will go point by point. Actually, I have lifted the question from an EMQ, so understanding this had become a bit difficult. Okay, so now this is a question where, she is in 3rd day of delivery. She has had pulmonary embolism. She will definitely get 3rd therapeutic dose. Yes, Novia, you're right. It will be therapeutic, therapeutic dosage. So obviously it is not prophylactic. Now, just to ask you, she has delivered and now she has pulmonary embolism. She will get therapeutic dosage for how long? Therapeutic treatment for 3 months. Okay. So CS under GA, under SA, first these 3 options are obviously not applicable. Prophylactic LMWH for 10 days. First of all, it won't be prophylactic. It will be therapeutic. Then 10 days after delivery, no, it will be 3 months. Yeah, yes, Novia, yeah, you have got it right. Yeah. So the last option that we have, thrombophilia testing, is recommended. So what I wanted to highlight with the question is, once the pregnancy is over, we can check for thrombophilia in a patient who has had such events. Okay. So the correct answer for this particular question would be E. That is, thrombophilia testing is recommended. Did you understand? Actually, this was an EMQ. There were about 10, 11 options. Okay, okay. So if you're all clear on this one, what I actually wanted to emphasize with the question is that you need to do a thrombophilia testing, but you cannot do that in testing. We have to do it. When will it be done? Yes, we will do it by when the pregnancy is over in her puerperium, we can carry out the thrombophilia testing. And yes, by exclusion. Right, Sabha, you're absolutely correct. Okay. Okay. Should we wait for PP period to end? Ideally, we should wait for the PP period to end for, yes, after puerperium, I get that, so that all the factors come back to their normal level. So thrombophilia testing is recommended. Okay. 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 Let's see. Okay. Yeah. Thank you, you all, for being so attentive and actually solving the questions with me. Now I'll go mute. I want you to read this EMQ. Actually, this is an easy EMQ, but I want you to see all the three answers in the chat box. Okay, go through all the questions. Just practice an EMQ with me today. And on the clock, I have the timer. I'll give you 3 minutes to solve this EMQ. Oops, 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 oops. Okay, I hope you have not seen that. Yes, answers are coming in, Snovia. Yeah, you are right. C. Okay. But I want you to correct, solve the entire EMQ together. Okay, okay, Malak. Malak has come up with all the three answers. Okay, Snovia has given us answer for the second one. Okay, I'll go mute the total time. Okay. Okay, 1 more minute to go. Can you all just summarize and put your three answers together in the chat box? Yeah, Malak had put in a thumbs up. Yeah, you get the question. Okay, I'm happy. Yeah, yeah. Hanifa, I'm happy. 30 more seconds for rest of you. Okay, so time is up with us. Now, let me have a look. Snovia, Hanifa, and Sabah. Sorry, I can't read your name. And then Malak, Humo, Samina. But the first one to answer all the questions, correctly was Anu. Anu was in the last class, as far as I remember. Okay. So yes, the correct sequence would be CED. So let's have a look. A 20-year-old lady, 24 weeks gestation in the second pregnancy, admitted with swollen right leg. So we know provisional diagnosis of DVT is made, and we all agree anticoagulation needs to be started. Yes, so I have hammered enough, and you all know that we first need to have these particular things screened. So see, now moving on to the next question. 31-year-old lady, 5 days post-delivery after cesarean section, admitted with shortness of breath, chest pain, hemoptysis, all the buzzwords in a row that we have for PE. Okay? Because see, under the stress of the exam, what happens when something like this comes? We are thinking of myocardial infarction, we are thinking pneumonia. What has happened? You know, when all the things are together in your brain, things get jumbled up. So always remember, chest pain, hemoptysis are buzzwords for VTE as well. So the chest X-ray is normal. Now what do? We do VQ scan or CTPA. CTPA. Okay. Now, all of you have answered it correctly, VQ scan or CTPA, option E. But now I would be a bit more, critical and ask you whether VQ scan or CTPA. Okay, I know. The best answer is VQ scan. Saba Umuya. You're all correct. So that particular comparison chart has now been driven home. You have all correct. Okay, Malak and I think there was Snovia. Snovia, am I pronouncing your name correctly? Okay. Sorry, I cannot read your name. You're also correct. VQ, Dr. Samina. Yes, if X-ray abnormal, then CTPA. Vein mnemonic. Yeah, I'm so happy actually. Okay, let me put a thumbs up. You remember my mnemonic? Okay, Umu. Yeah. You're all correct. So it would be VQ scan. Now, moving on to our last question. 32-year-old woman in her first pregnancy came with left leg swollen at the calf. Measures 3 centimeter more than right calf and is also painful and red. Compression Doppler ultrasound is negative. So if it is negative, but over here, everything is pointing just towards DVT. So we will say that the suspicion of clinical level is high. So we will repeat a scan on day 3 and day 7. And now I want the chat box, blazing with another answer, another aspect is whether in this situation we continue LMWH or we stop LMWH. The clinical suspicion is high for DVT. Discontinue. Okay, yeah, Sabah, you are right. Okay, Hanifa, can you explain the first question? Okay. So, 28-year-old lady at 24 weeks gestation in her second pregnancy, admitted with swollen right leg. Provisional diagnosis of DVT is made. Anticoagulation needs to be started. Whenever we are starting anticoagulation to a patient, okay, whenever we are giving her LMWH or unfractionated heparin for that matter, one of the very first set of tests that we need to do for her is this particular set of baseline screening. This we have discussed today. We have discussed in our previous class also. Always remember that before we put her on anticoagulation, all these baseline parameters need to be checked. The bloods need to be sent for these particular parameter. Okay. Yeah, Sabah, you got it right. For PE, continue. And Umu has given a thumbs up to you. Yeah, true. Okay, vein mnemonic. Okay, I cannot read your name, but because if you say my mnemonic, I should give you a thumbs up because then I've given it to Umu. So I should give it to you as well. So, okay, a thumbs up from me as well. Okay. Yeah. Her diagnosis already made, and according to algorithm, the tests are done. Okay. Yeah, the tests are done. Okay, you're going through the algorithm. That is fine. But then also, there is no other option within the answer that suits a situation better. See, for DVT, we are putting her on anticoagulation. And there is no mention whether she is obese or having any of those criteria where we need to measure anti-10A activity. So that is also not, part of, that is not, necessary, or that cannot be the answer. Okay, my name is Raghav. Okay. Let me give you a thumbs up for that as well. Okay, Raghav. So, all right. So, yeah, this is not one of the answers because anti-10A activity, if you ask, there is a question that will follow where anti-10A activity about that. We do have a question later also. We monitor only in therapeutic cases. therapeutic dosage cases, but if the patient is less than 50 kg, more than 90 kg, or having any of the comorbidities, or is having recurrent PTE, okay? So if not, then it is not relevant. CXR is not relevant. USGDP, PQ scan, these are not relevant. So actually, always don't go by the algorithm. Often we also need to, look at the question and exclude the other answers. So before we start anticoagulation, just we need to note these factors. Yes, I know in the algorithm it was high up, but this is the next step that we need to take in account. Okay. Okay, so yeah, now we are moving ahead with our next question. A 30-year-old lady with body weight of 96 kilograms at 22 weeks of gestation had been suspected with DVT. Which of these statements are correct? Not are correct, is actually is correct. So, okay. E, Malak. Okay, okay. Yeah, Sabah, E. Yeah. Okay, Snovia, Raghav. Okay. All of you have given the correct answer. So let's just analyze point by point and discuss this question. I was expecting a question from you all when you look at the options. Okay, yeah, Sava says less than 50, more than 90. Yeah, that is what I was telling in the next, in the previous question only, that we do have a question on anti-TNA activity. Okay, negative compression play excludes the diagnosis. Well, no, not always. So, because not always, that is why we repeat on day 3, day 7 in high suspected cases. Positive D-dimer confirms DVT, no, not in pregnancy. Thrombophilia screen should be requested at presentation, no, because she is 22 weeks pregnant at presentation. LMWH never causes HIT. See, we know that LMWH never causes HIT is the wrong answer, but always, suppose in a question where you are, not knowing very many things about the topic or understanding, or maybe you have not read the guideline properly, but whenever you come across any particular option where something is like never causes this, always causes this. Normally in GTG, whatever we have, in fact, these are all evidence-based medicine, okay? So never or always or something that hard and fast is not usually the correct option. I just wanted to have you give you the idea of that. Yeah, and you're right, it's E. So peak anti-TNA activity should be assessed 3 hours post LMWH administration. Well, I was expecting that some of you would jump at me with this particular query, that why 3 hours and not 4 hours. Nobody did. I'm lucky. But then, yeah, it should be ideally 4 hours, but the options were like this way. It mentioned 3 hours. And because we have had a look at the rest of the options, and none of them suits any better. So maybe this, not maybe, actually this is the right answer that they have given, that assessed 3 hours post LMWH. But the guideline mentions 4 hours, but okay, we will make do with 3 hours for the lack of any other better option. Okay. So are we clear so far? Okay, now, yeah, that was the right answer. Now moving on with our next question. 36-year-old primary gravida at 36 weeks of gestation with low-grade fever. Remember, that was a buzzword. Chest pain and cough. Her observations are stable and she is comfortable at rest. What counseling should she receive? Yes, you are all correct. The correct answer is C. CXR shows signs of PE in all cases. See, like something hard and fast like this never happens usually. And of course, we also know that CXR never shows signs of PE in all cases. So that's the wrong option. CTPA increases the lifetime risk of maternal breast cancer by less than 10%. That's the wrong option. But can anybody tell me what was the right percentage? There was that comparison slide. What is the increasing of the lifetime risk? Okay, we have an answer. Yeah, Malak. 13%, 13.6%, but okay. Yeah, Umu. Perfect. Okay. 13%, yeah, more correct answers. Okay, if leg Doppler studies are not suggestive of DVT and the clinical pictures suggest PE, further imaging is necessary. True, so this is the correct answer. Perfusion component can be omitted. No, perfusion component cannot be omitted. Perfusion is actually the blood flow through the veins. And obviously, how do we detect if we omit that? We can omit the ventilation component. So that is a wrong option. And VQ scan increases the risk of childhood cancer. And that's a wrong option. I need you to tell me the risk ratio. This is 1 in 10 lakhs. 1 in how many lakhs, Nubia? Ventilation can be omitted. Yeah, true, Umu. Okay, so risk increases by how many? 1 in 1 lakh? No. Okay. Yeah. 3 in 1 lakh. Okay, so yeah, you have just messed it up a bit. 1 in 3 lakhs. Hanifa, you're right. 3 in 1 lakh. Just, mm, you have just, switched the numbers, swapped them actually. Okay, so now we are clear on that one. So this is the last question for today. Do have a look. Okay, answers are coming in. Okay. Okay. Um, Answers are coming in, but anybody else with a different answer? Actually, I don't hold you all responsible, because this is something which is not there in the Green Top guideline. Neither have I discussed it in the class. Now, let me give a hint. That this is from one of the scientific impact papers. And when I discuss SIPs, this one SIP is really important, you know, that is air travel in pregnancy. That is one important SIP. Okay, I have got a combination of answers, but okay, let's discuss this question. This is not from the Green Top guideline, as I said, it is from the scientific impact paper, an important one on air travel and pregnancy. Do have a look at that later, maybe, but questions are formed from there because air travel and pregnancy is an important chapter. Okay, absolute incidence is doubled by prolonged air travel. That is not the right answer because absolute incidence of VTE is increased by 3-folds, and there is 18% increase for every 2 hours of air travel. Okay. Overall incidence of symptomatic VTE is low at 1 out of 4,600. Well, this is the right option. But, well, how in the world would you know that? Okay, this is very factual. But there was this question was from strategy. So have a note that SIP of, air travel in pregnancy is important. This percentage is important as this is the correct answer. There was no way you could have guessed it, but maybe a bit of working around and excluding we could have done. Aspirin 75 mg OD for low risk women. No, there is no role of aspirin. Okay. Prophylactic LMWH on the day of travel and for several days afterwards. I think a few of you have answered this as the correct one. We do give, but we give it for women with obesity, medical comorbidities, symptomatic thrombophilia, that is a patient having thrombophilia and history of VTE and likewise, and a history of previous DVT. So such high-risk patients, we will give prophylactic LMWH on the day of travel and for several days afterwards. Don't jump at me as to how many days afterwards. This is how the SIP mentions. So that is what I can tell you. Maybe this decision regarding this will be taken by a multidisciplinary team. And graduated compression stockings worn during flight reduces risk by 50%. Okay, reduces risk, that is a relative risk of 0.1, but not by 50%. Okay, okay. Prophylactic for any air travel over 4 hours would be by graduated compression stockings. Okay, and if the patient is having any of these, high risk factors like obese, medical comorbidities, symptomatic thrombophilia, previous DVT, then we will consider giving prophylactic LMWH. And by medical comorbidities, what was the list? If you were there in the previous webinar, the intermediate risk factors, it had a lot of medical comorbidities mentioned like nephrotic syndrome, type 1 DM with nephropathy, active SLE, heart failure. Obviously, with heart failure, a patient won't be traveling, for more than 4 hours. But such are the medical comorbidities that we mentioned. A cancer patient, maybe with pregnancy. These are the situations where we give LMWH. Otherwise, we will suggest graduated compression stockings to the patient. Okay. Okay. Can you explain E? Okay. They are telling that the stockings, if we wear them, reduces the risk by 50%. Well, it reduces the relative risk, that is, of having a situation of DVT would be 1 in 100. That much reduction will happen, but wearing the stocking 1 in 100 might have a situation of having a DVT, but it is not exactly by 50%, but more than that. All right. So with that, we come to an end of today's discussion and leaves room for, I think, more discussion, because today we came up that VTE doesn't end with GTGs only. There is also an important SIP that we need to know. Okay. So looking forward to having you all in our next session with us, which is the progressive course that is dated to start tomorrow, 8th of November. I hope I'll find many of you in the class, many of you who are preparing well. I can actually make out from your answers that many of you are actually ready with your preparation, and I think a bit of a boost towards the end will help you in acing your exam on the 16th of January. Okay. Yeah, many thank you messages coming in. Okay. Thank you so much. It was a very fruitful discussion. Having an interactive audience is what I could have only asked for. Thank you, everybody. Okay. Sabha with a lot of hearts and okay. Yeah, from Raghav as well. Hanifa, thank you. Malak. Okay, Umu says, I've learned a lot. I'm glad that I could be of help. Thank you, Anu. You all are wonderful. It's not just about me. You all are wonderful. You have been a wonderful audience. You have been wonderful students. Snovia, Dr. Tasneem. Okay, thank you. iPhone. Okay, okay. It's a very helpful session. Thank you. I'm glad that I could be of help. Okay, so signing off today. And I just hope to see you again next time in our class. Thank you so much. Thank you so much, all of you. With that, today's session is over. See you all again sometime.